Good morning, students. Today I am going to take the third lecture of the pharmacodynamics. Till now, we have talked about the receptors and various sites of drug action. So, at the end of today's lecture, you will be able to understand what dose response curve is and what are the different parameters which we can assess from the dose response curve, such as efficacy, potency, and the slope. So, if we draw a dose response curve, so if we are drawing dose response curve, we get a parabolic line like this. So with the increasing dose, the response goes on increasing until we reach to a maximum response, which is the 100% response. And beyond this, if we are going to increase the dose further, the response is not going to increase. So the dose at which the response is not going to increase or the maximal response is reached, that is known as the ceiling dose. Similarly, if we take the doses in the log dose form and draw, we get a sigmoid curve. And the importance of this sigmoid curve is that we can draw a large number of doses using a dose response curve, and it will be a compact one. And more or less, and second most important thing with the log dose response curve is that we get a straight line that is between the 25 to 75% of the response. So we can get a direct inference that with the increasing dose, the response is also getting multiplied. So we take the effective dose in the 50%. That means the effective dose 50 ED50 is the dose which is required to produce the 50% of the response. And from this we can calculate. So this is the importance of the log dose response curve. So coming to the various parameters which we can come to know with this log dose response curve we use commonly. One is the potency. So potency is the amount of the drug which is required to produce a response. So to produce a response, the amount required of the drug is the potency. And efficacy is the maximum effect which can be produced by using a drug. So clinically, it is the efficacy which is more important than the potency because it is the mainly the response which we want to know or which we want to see. And from the slope, we can get an inference that whether the drug is having a narrow therapeutic index or a wide therapeutic index is that when the slope will be more straight, more steeper, that means with the small increase in the dose, more of the response is going to increase or side effects can happen. So that drug will be having a narrow therapeutic index. And more the slant the curve is, that means the wider the therapeutic index is, that means more safer the drug is. So if we plot a dose response curve of two drugs, say A and B, and what these two curves are telling that with the use of drug A, we are getting the 100% response, while we are using the drug B, we are getting 50%. So the maximum response with the drug B is 50%. That means the efficacy is the maximum response by a drug. So the which drug is having the more efficacy? That means drug A, since it is producing 100% effect, that means it is more efficacious as compared to drug B. So the curve which is higher in the log dose response curve is having more efficacy. The more the height, the more the efficacy of the drug. Similarly, we can compare the potency of two drugs. Here, the log dose response curve for two drugs A and B has been plotted. So if we see, there is a rightward shift with the of the dose response curve with using the drug B. That means for producing the similar effect, we are requiring more amount of the drug. That means drug A is more potent than drug B. If we see the effective dose 50, ED50, so lesser dose is required for drug A, while for B, we are requiring a higher dose. That means a rightward shift of the log dose response curve means more requirement of the drug. And so the potency of such drug is lower. Drug A is more potent as compared to drug B, or drug A will be required in lesser amount as compared to drug B. So this is an exercise. Uh, we have to know which drug is more potent or which drug is more efficacious. So from this graph, we can come to know that we are seeing three curves, so A, B, and C. More is the height, more the drug is potent. That means A is more potent as compared to C and B. C is more potent as more efficacious. Sorry, more efficacious as compared to B. But if we are going to compare the potency, we are seeing that drug A is required in lesser amount to produce the same amount effect, but drug B we have to use more amount. So if we compare the potency, so rightward shift means more less potent drug. So drug A is most potent, B is lesser, and C is the least potent among these three. Similarly, same exercise is the log dose response curves of four drugs A, B, C, D. So if we see A and B are equally efficacious. That means the maximum effect they are producing is the same, but they are drug B is less potent as compared to A. And when we compare D and C, we see that the efficacy of these D and C is same equal, but D is more potent as compared to C. So from the log dose response curve, we can come to know about the drug selectivity also. So A and D are the effect of salbutamol on bronchodilation and cardiac stimulation. So we see that there is a large gap between A and D. This is for salbutamol on bronchodilation and cardiac stimulation. So we see a large gap is there. That means little drug or lesser drug is required for bronchodilation as compared more drug will be required to produce cardiac stimulation. That means salbutamol is more bronchoselective than the cardioselective. So it is safer to use this drug in patients who are having some cardiac problems. While if we see drug isoprenaline, so B and C are the effect of isoprenaline on bronchial smooth muscle and cardiac muscle. So there is a lesser gap. That means more or less the same amount of drug will produce the bronchodilation as well as the cardiac stimulation. So if we are going to use drug isoprenaline for patients with for producing bronchodilation, so the drug will produce more of tachycardia also. So drug isoprenaline is not very selective as compared to salbutamol. So salbutamol becomes more selective for bronchial smooth muscle and more safer for the use. So next terminology is very important, that is therapeutic index, by which we can come to know about the margin of the safety of a drug, and it depends upon the factor of the dose producing desirable effect to the dose eliciting toxic effect. That means 50% of the population animals they are having the dose lethal dose divided by the effective dose in 50% of the animals. This is commonly used for the experimental purpose, and it should be more than one. That means effective dose should be lesser as compared to the lethal dose, otherwise we cannot use such drug. So from the log dose response, we also come to know about the therapeutic range in which we can use the drug. So from the therapeutic effect, if we are going to see, it is the log dose response curve. Blue line shows the therapeutic effect. So with the dose at which the minimal therapeutic effect is seen, uh, to the dose which is going to produce the maximum acceptable adverse effect. So that dose range is the therapeutic range in which we have to use the drug. That means it is the minimum drug which is required to produce the effect which we want to produce the effect with while using a drug, to the maximum tolerated dose or maximum side effect which are acceptable. If a drug is having more acceptable, that means the drug is more safer. That we can also know from the log dose response curve. Therapeutic index is commonly interchangeably used with the therapeutic range, and it is the optimal therapeutic range of the plasma concentration of a drug which most of the patient experience the desired effect. So if a drug is being used in the therapeutic window, that means more the drug is safer. Similar, like cyclosporine, we have to the therapeutic range is 100 to 400 nanogram per ml. Carbamazepine, it is 4 to 10 microgram per ml. That is plasma concentration. Digoxin is zero point 0.8 to 2 nanogram. Lithium 0.8 to 1.4. Phenytoin 10 to 20. Quinidine 2 to 6 microgram per ml. So these are drugs which are having a very narrow therapeutic window. That means they are to be used very precisely, very accurately, so that the plasma concentration, if it falls below this, we are going to lose the effect, and if it falls above it, we are going to have the serious side effects. So agonists are those drugs which has both affinity as well as intrinsic activity. They trigger the maximum pharmacological response, and they mimic the endogenous substances. Like methacholine is a cholinomimetic drug which mimics the effect of the endogenous acetylcholine on the cholinergic receptors. It has 100% affinity, and its intrinsic activity is one. That means it is going to produce the maximal effect. So synergism is means together, and in ergon means work. That means two drugs are working together. When the action of one drug is facilitated or increased by the use of other, they are said to be synergistic. And in a synergistic pair, both drugs can have the action in the same direction, or given alone, one may be inactive. That means it is not producing response. But when it is given with the other drug, it is going to have its own effect in the same direction. So synergism is of two types: additive and the supra-additive. Additive means where the sum of both effect of both the drug is equal to the individual drug summed together. That means effect of drug A plus B is equal to drug effect of drug A plus effect of drug B. Example is aspirin and paracetamol. Both are cyclooxygenase inhibitor and have and produce the analgesic and antipyretic use. Nitrous oxide with halothane as general anesthetic. Amlodipine and atenolol as antihypertensive. Glibenclamide and metformin as hypoglycemia, etc. So these drugs are having just the additive effect. Supra-additive or the potentiation means with the sum of both the drugs is greater than the effect of the sum of the individual drugs. That means they are not only just working in the same direction, but their combination is going to produce better response than the individual drugs given together summed, because they are going to act through different pathway. These drugs are going to act through different pathway, but their use is common. Like if we are giving a patient acetylcholine with physostigmine. Physostigmine, I have told you, is a anticholinesterase inhibitor. So it will inhibit the acetylcholine metabolism. So more of the acetylcholine will be there. So based on the inhibition of the breakdown, this combination is going to have more of acetylcholine and more of the effect will be. Similarly, I have talked about levodopa with carbidopa. What carbidopa does is inhibit the peripheral metabolism of levodopa. So what will happen ultimately, that more of the levodopa will be available to be converted into dopamine, and more fruitful this combination will be. Similarly, adrenaline with cocaine or desipramine. Cocaine inhibit the neuronal uptake, and more the synaptic level of the adrenaline will be there, more the adrenergic stimulation will be there. Similarly, sequential block of the folate synthesis occurs with the sulfamethoxazole and trimethoprim. So this combination is going to have the potentiating effect. In an antihypertensive working in two directions producing the same effect. So similarly, these drugs are there. So these are supra-additive ones. So these are the log dose response curves for different drugs. A is the agonist when given alone. So it is the log dose response curve. Red one is the log dose response curve. B is another agonist in a fixed submaximal dose producing 40% response. So this B when given with A is going to produce the effect which is equal to A plus B. That is, it is additive effect. While C is a drug which is potentiating drug, which itself has no agonistic activity, and so when it will be combined, it is going to potentiate the effect of A further. So the sum total is not just equal, but it is higher as compared to individual A. Coming to the antagonism between two drugs, when one drug decreases or abolishes the effect of another drug, they are said to be antagonists. That means the effect of A plus B is less than the effect of A plus effect of drug B individually. So the different types of antagonism can be chemical antagonism. So when a patient is on heparin, protamine is the chemical antagonist for heparin because it is a positively charged molecule, and because based on this chemical structure, it is going to bind with the heparin and inhibit its action. Similarly, chelating agents in the case of heavy metal poisoning. So these binding will be uh, because of the chemical structure, and such inhibition is known as the chemical antagonism. Next type of antagonism between two drugs can occur because of the physical antagonism, where charcoal absorbs alkaloids. So alkaloid poisoning, charcoal is given and can prevent their absorption. So they are used in alkaloid poisoning. So based on the physical property of the charcoal, the drug is being given with the alkaloid poisonous drugs. Next is the physiological antagonist or the functional antagonist. When two drugs are given, they are acting on different receptors or by different mechanisms, but they are having the opposite effect uh, on the same physiological function. That is, have same pharmacological effect, but in the opposite direction. So such type of antagonists are known as physiological antagonists. Like on blood pressure, histamine and adrenaline, they are having uh, uh, or the bronchial muscle, they are having just the opposite effect. Adrenaline causes bronchodilation, histamine causes bronchoconstriction. Histamine acts through the histaminergic H1 receptor, adrenaline is going to act through the beta 2 adrenergic receptor. The receptors are different, the drug are different, but they are acting on the same target cell but in the opposite direction. So such type of combination is said to be having physiological antagonism. Then we have the pharmacokinetic antagonism, where two drugs given together, they are going to affect the absorption, metabolism, or excretion. Like when I have talked about the metabolism, I told about enzyme inducer and enzyme inhibitors like that. So those drugs, all they were pharmacokinetic antagonists. Like warfarin in presence of phenobarbital, warfarin metabolism is increased because phenobarbital is a enzyme inducer and its effect is reduced. So there can be bleeding. Similarly, pharmacological antagonism is there when pharmacodynamic antagonist between two drugs which are acting at same receptors is there. So this antagonism can be reversible or the irreversible one. Reversible means competitive and the irreversible is the non-competitive one. Reversible or the competitive antagonism means that this inhibition is commonly observed with antagonists that bind reversibly to the same receptor site as that of an agonist, and by increasing the level of the agonist, we are going to overcome. That means it is reversible. This type of inhibition can be overcome by increasing the concentration of agonist. Like atropine is a competitive antagonist for acetylcholine. Next is the irreversible one, where the antagonist dissociate very slowly or not at all from the receptors and results in a conformational changes, because of which the agonist cannot bind. This antagonism cannot be overcome by increasing the concentration of the agonist. So these are the log dose response for curve for the agonist and the competitive and the non-competitive one. When we see the graph A is the log dose response curve for the competitive for the agonist. When we are giving the competitive antagonist B in a one times concentration, and we are going to increase the dose of A, that means the graph will shift towards the right. So we are getting the maximum effect by increasing the concentration of the agonist. And when we are going to increase 10 times the dose of the competitive antagonist, we are requiring more amount of drug A or the agonist, and we can still get the same response. So this type of rightward shift, parallel shift from the dose response curve, we come to know that this drug is a competitive antagonist. While in the graph B is the non-competitive or irreversible antagonist is given. So red line depicts drug A is given alone. When low dose of the drug C is given along with drug A, so there is conformational changes in the receptors. So the maximum effect is not going to be produced even though we are going to increase the dose of it. And if more 10 times dose is given, still the efficacy is going to decrease further. So the efficacy is going to decrease, the potency is going to increase with the non-competitive antagonist. We are not going to achieve the maximal effect with the non-competitive antagonist. So thank you very much for your patient listening.